All right, we are live. Welcome, everybody. This is Dr. Michael K. from the Center for Functional Health, and I'm so happy today. I am speaking with Beth O'Hara, who is an expert in MCAS. That's Mast Cell Activation Syndrome. And I've been really looking forward to this interview because I hope to dive deep, learn more so I can help my patients and we can help you guys out there. So, Beth, thank you very much for taking time out of your busy schedule. I know it's hectic and crazy and taking time to speak with me today. So, welcome, welcome.
Thank you, and I'm just so happy to be here with you and get this information out because I find a lot of times this is a game changer for people who've just been stuck with their health. They keep going to specialists, they're not getting answers, and they can't figure out what's going on.
Yeah, mast cell activation is absolutely huge. We see it, and I know obviously you see it. A lot of the docs I work with, I work with a lot of our local medical community, and they just shrug their shoulders. So that's the time they say, "I don't even know what you're referring to." So before we dive deep into MCAS, Howard's on with us right now. Welcome, Howard. Thank you for coming on, and we will ask that question about MTHFR. But before we jump into that, I want to know your journey. How did you get here? Because not everybody gets it. Not everybody understands what MCAS is. So, what has your journey been like?
Well, it's been a personal journey. I'm into this because it was part of my own recovery and really my survival. So when I was young, we moved out to the country into this old farmhouse, and this was an important part of this story um, that I'll come back to. After we moved out there, my health started going downhill as a child, and just mystery things, strange things. Nobody knew why I was dealing with. I had a lot of allergies, terrible hives. I'd be itching head to toe. I'd itch at night, and from the scratching, I'd scratch my skin off. I'd be, have blood on my sheets in the morning, and it was just miserable. By the time I was in high school, I'd had two head injuries and I just crashed hard to where I could hardly get out of bed. And I was always a really driven young person. And I had decided at a young age that I wanted to be a physician, a medical doctor. So my whole focus was on getting to medical school. And I was fascinated. I was one of these weird little kids that wanted to read Grey's Anatomy. That's what I wanted for my 16th birthday. And I'd find growing out in the country, we'd find bleached bones from animals that had died, and I wanted to put them back together. So um, just to show you how important that was to me. And I drove myself too hard in college again. I lived in some different places that were moldy, and that house that we had moved into had mold, but we didn't know it. Nobody knew about mold back then. I had also picked up Lyme. And these are two of the major root triggers of mast cell activation syndrome. So that's why I tie it into the story. And by the time I got to the end of my junior year in college, I was so sick. I, again, couldn't get out of bed. And I knew I was going to barely finish out my bachelor's. And that's what happened. And I had a full scholarship to medical school. I had to turn it down. It was one of the most devastating things. And I wanted to be a neurologist. And I was very good at dissection. I wanted to be a surgeon. So instead of getting to become a neurologist or neurosurgeon like I wanted, I had to become a chronically ill patient. I made the routes, Dr. Michael, I had totaled up over 75 practitioners by the time I figured out what was going on with me. That's a lot of practitioners. And by the time I was 28, I could hardly walk. I was using a cane to walk and really hobble. My friends were going out dancing, and I was wearing orthopedic shoes. And I had severe anxiety, horrible brain fog. I could barely read a book, severe chronic fatigue. There were periods of time I didn't know if I was going to make it. And everybody I went to, either the best said, I've never seen this before. I don't know. And some of the, practitioners who really weren't great practitioners told me that it was all in my head and I wanted to be sick and there was nothing wrong with me. So that was devastating. I share that because I know it's a lot of people's story. And unfortunately, in my own practice, I hear that story every week. People come in, they tell me that story, same story. But I persisted. And if I have anything, it's tenacity. And so I kept going. And I knew if I could find these keys that I knew were out there, I just knew in my bones they were out there, I'd be able to start to put this puzzle piece together. The first thing I figured out was histamine intolerance. Then I started learning about Mast Cell Activation Syndrome before it was even accepted as something official. It was still in these theoretical phases. And I said, that's it. That's what I have going on. Because of all these mysterious symptoms and all these different systems in my body. My GI tract was a mess. I had trouble with breathing. And then I had to dig into, well, why were these mast cells part of my immune system getting so dysregulated? And that's when it was like, well, Lyme. Okay, well, that made sense. But I couldn't tolerate any Lyme treatments. And I was getting more sensitive over time to where I couldn't take supplements. And then we figured out the mold toxicity. And that, in my own practice, is the number one root cause. So we just want to make sure I put that on the table because a lot of people think, oh, I have mast cell issues. If I can just control those mast cells, I'm going to get this handled. But you got to dig under why. Why is it all dysregulated? But I got my life back, Dr. Michael. I got my life back. I went back to graduate school. I got 2 graduate degrees. I'm so excited. 2 weeks ago, did a 5-mile hike, and that's my absolute best since my early 20s. I had 1 year of reprieve, and I was able to be physically active. So that's my best in 20 years. And I go hiking most weekends, and I have a really good life. I still have to take care of my health, and I have to do more health maintenance than, your average person on the street. But I run this busy practice, and things turned around dramatically. And I just want to give that hope to people out there who are struggling with these things.
That's a fantastic journey. I mean, and people are struggling. Like you said, they come to the office and they're overwhelmed. They're overwhelmed with their symptoms. They're overwhelmed with the fact that they have no answers. They're overwhelmed with all the research that they're doing on Google, and they're not getting any direction. So if we can take it back to the very beginning and say, okay, let's talk about what a mast cell is, what they do, how it plays a role in our immune system, and how is mast cell activation syndrome different from, oh, I just have a histamine problem?
Yeah. So mast cells are key immune cells in our bodies, and they're one of the most complex cells in our bodies, and one of the longest lived, which I find really interesting. They live over a year. And these mast cells, I think of them as our frontline defending, sensing, and protecting cells of the immune system. They have hundreds of receptors on the outside, different types, that can register anything we're coming into contact with outside of our bodies or inside of our bodies. So they're sensing for toxins, they're sensing for bacteria, viruses, molds, candida, parasites. They're sensing for injuries. They're sensing for stress as well. They're highly sensitive to stress. And they are very linked in with the nervous system, which is also interesting. And they are in almost every tissue in our bodies. They're in our skin. They're in the lining of the sinuses and the nose, all the tissues around the eyes, the whole GI tract from the mouth all the way down. And they're in the esophagus, they're in the stomach, they're in the lungs, they're in our heart, they're in our muscles and our bones. They're made in the bone marrow. And they're in our joints. They're in all the reproductive organs. So you name it, they're 99% likely they're there. There's very few tissues they're not in. And then what they do is they respond to what's happening. So one of the probably easiest examples people can relate to is if you cut your finger and you don't get it cleaned out right away, and you've got dirt in there and bacteria in there, and it starts to get red and swollen. That initial redness and swelling is contributed in large part by the mast cells producing some local inflammation to protect you from infection. Then they're releasing these other mediators. Histamine is the most well-known. And then the other word that's become a household name now is cytokines.
Yep.
Mast cells release a lot of cytokines. These are communication molecules, and there's all kinds of cytokines. There's pro-inflammatory and anti-inflammatory cytokines. And they release all these communication molecules. And they have these really neat diagrams I've found in studies of how they communicate to the rest of the immune cells, and the immune cells communicate back to the mast cells. So it's almost like they're the conductor of the immune system. And then you asked about the difference between just mast cell issues and histamine issues. So where do these mast cells go off the rails? They normally should be responding and then calming down, responding and calming down. And people may have all kinds of different symptoms, and that's why this has made it so challenging for practitioners to wrap their heads around, or even for it to get recognition, because it looks like so many things, and it depends on what tissues are affected and systems in the body. So I obviously had the skin symptoms with the hives I was talking about. My cheeks are always a little reddish. I never wear blush because I look like a clown if I put blush on, or people may have a pale complexion. But people can get eczema, psoriasis, all these different things with the skin. But not everybody has those skin symptoms. And that's a misunderstanding out there, that you have to have skin symptoms to have mast cell issues. And that's not true. I have a lot of clients who have no skin mast cell issues, but they've got significant issues in their GI tract. They're having issues with acid reflux or diarrhea. A lot of the irritable bowel disorders are mast cell related, things like colitis, things like Crohn's, all of these types of bowel issues. And some people may have those bowel issues, and they might have breathing issues. They get tightness in their chest, or it might be in the cardiovascular system. There's lots of mast cells all along the blood vessels. So people can have trouble with high blood pressure or low. Low is more common, depending on which mediators are getting released from those mast cells. Some people have a lot of trouble with their nervous system. They might have anxiety, sleep issues, depression. It can show up in all these different ways. So you get these very different presentations based on which mast cells are affected. So the mast cells can be releasing histamine or any number of their other mediators. And the latest estimate is there's over 1,000 different mediators these mast cells can release. So we've got all these cytokine possibilities. These are things like interleukins, there's chemokines, they release tryptases. There's all kinds of different mediators. I don't even know all of them. I don't know anybody who knows all of them, and they're still discovering new ones every year. And there are some really brilliant mast cell researchers. Those are the ones that know everything about what we know on those mediators. But mast cell activation syndrome is where the mast cells get dysregulated from chronic exposure to toxins, pathogens, and or trauma and stress. Could be physical injuries as well. So it can be set off by a surgery, it can be set off by a really bad car accident. Any of these things can tip it off. And that's going to be an issue with any number of these mediators. So it's much more complex than just histamine intolerance. So histamine intolerance is where we have an issue where we've got more histamine than our bodies can break down. And it's related to mast cell activation because it can trigger more mast cell activation. But histamine intolerance, we have these enzymes in our bodies that break down histamine. So these are going to be enzymes. Some people maybe have heard of, like DAO, HNMT is one that stands for histamine N-methyltransferase. DAO stands for diamine oxidase. And there's a tie-in with methylation. So that's part of this MTHFR question we can come back to. And There's a number of others that are less well known. If those aren't operating really well, if we've got a lot of genetic variants there, if our methylation's effective, we have certain nutrient deficiencies like B6, just as an example, we may not be able to make enough of those enzymes. If we have small intestinal inflammation where all of our DAO is made, the vast majority of it's made in the intestines, we can't make enough DAO if there's inflammation there. So then those histamine levels can build. But if somebody only has histamine intolerance, that's simpler. You just fix, they might be able to do low histamine foods, reduce their load that they're putting into their body, reduce the mechanisms that are causing increased histamine levels in the body, and work on supporting those enzymes. They're usually feeling much better. People can have mast cell activation syndrome and not have histamine intolerance. And they may not have an issue with histamine. They may have an issue with some of the 999 plus other mediators. People can have just histamine intolerance and not have mast cell issues. Most of the people I work with have both, and that's the more significant presentation, is when you've got these mast cells that are super sensitive, they're over responding to everything, and then you've got this load of histamine you can't clear out of your body, and then it keeps triggering the mast cells.
Okay. I now have 47 questions after that. So that's fantastic. So if a histamine intolerance goes unchecked, can that become like a complete MCAS presentation?
In terms of symptoms?
Yes.
You mean,
can a histamine intolerance progress to like a MCAS presentation?
So it depends. Potentially, theoretically, but generally, there's going to be some very significant root causes for the mast cell activation syndrome that are not necessarily as much of an issue if people only have histamine intolerance. So I'm trying to think how to put this. Histamine intolerant symptoms can look like mast cell activation syndrome. They're usually not as significant. Okay. So when people should start considering mast cell activation syndrome would be if they are doing a low histamine diet and maybe they've tried a DAO supplement and it's not getting better, or they get a little improvement, but it's just not enough. And that's what was going on for me. I worked really hard on that histamine. I got some improvements, but it just didn't even, tip the situation for me. If people have a lot of sensitivities to supplements, to foods, to medications, to chemicals, or things like perfumes, paints, gasoline, then we want to look more at mast cell activation syndrome. And I do have a symptom survey on the website, and people can go there at mastcell360.com. There's just a free symptom survey. They can go in the menu under what is MCAS and take that and see if that's something that they should consider. And that's based on the research on how these symptoms tie in and what symptoms have been correlated. And there's so many. Most autoimmune dysregulations, everyone I've ever seen that was studied in relation to mast cell issues also is linked to mast cell activation syndrome. So rheumatoid arthritis, we're talking about psoriasis, MS, Parkinson's, a lot of these disorders.
Okay. So, from a practitioner perspective, so many patients, as you can imagine, come in with these, the irritable bowel presentation, IBS-D, IBS-C-related diarrhea, constipation. We have the bloating. They come in with brain fog, MCAS and, nervous system involvement. It's hard for me to breathe. So as a practitioner, when we look at all this, this is something now, it should just be kept at the back of our mind all the time. And I know some patients will ask, well, why can't we just test for it? Is there like we can test for diabetes, right? Why can't we just test for MCAS? I know I was reading about, how the mast cell releases histamine and releases tryptase, and there's some testing on tryptase. So when a person comes in, other than a clinical presentation, is there some kind of blood work, lab work that you like to look at or you think about that says, hey, you know what, this is really leaning towards this, or is this just so much clinical presentation weighted more so?
Yeah. So this is the really challenging area in mast cell activation syndrome and what is still in evolution and has a huge amount of debate going on around. Mast cell activation syndrome only got an official diagnostic code in 2016. So
Oh,
that tells you how new this has been even accepted, as opposed to something like type 2 diabetes that has, there's just clear diagnostic criteria and it's proven and it's been tested and tested and tested for decades. So part of getting that official diagnostic criteria was there had to be some kind of criteria around it that would be generally accepted in traditional medicine and accepted by whatever organizations assign those diagnostic codes. What I can tell you, though, is the population studies have shown that mast cell activation syndrome is affecting between, at the low end, 9%, and at the high end, 17% of the general population. There's a lot of people. There's at least 1 in 10 people, and that makes it the most common and under-recognized condition affecting Western population today. When I talk with my colleagues and I look at my own practice, and we're seeing that in the chronically ill population, it's over 50%. So that's important as we talk about these diagnostic criteria, because the diagnostic criteria as it is currently, and we've got to start somewhere. So the diagnostic criteria is that, 1, there has to be symptoms in 2 or more systems. So like you described, the GI tract and the brain fog. So there you've got GI issues, you've got the neurological systems. Somebody might have a lot of issues with eye swelling. They might have the classic allergy symptoms with the sinuses, and they might have the skin symptoms. Someone else may have heart palpitations. They may have really low blood pressure. POTS is really strongly related. Hypermobility and EDS is very correlated. It can show up that way. So that's generally the easy one. Very few of our chronically ill population have symptoms in only one system. You just don't tend to see that. The second one is that there has to be an elevation, according to this criteria, in one of the mast cell mediators. So the ones that are often tested are tryptase, histamine. Sometimes they'll test PGD2, prostaglandin D2, and there are a few others that are tested. There are about 10 or 12 that are more commonly looked at. This is very challenging for a number of reasons. 1, tryptase is almost never elevated in mast cell activation syndrome. It should be used, and it was developed to be used to screen for more rare mast cell disorders like mastocytosis, which is a genetic mast cell disorder, or a genetic disorder called hereditary alpha tryptosemia. But tryptase is being used to rule out mast cell activation syndrome incorrectly, unfortunately. And that's just part of this all being really new. Then histamine's often used, urinary histamine. And many of these markers, they have to be analyzed through a cold centrifuge, which most labs don't actually have. And so they're not being often analyzed correctly. The other thing that's happening is that these markers are generally up and down the bloodstream within about 10 or 15 minutes. And then they'll drop back down again. You can catch somebody who has vascular involvement. So these mediators are being dumped into the bloodstream. But what if they don't have vascular involvement? What if it's relegated to the gut, to the lungs, so that, these other tissues, the muscles, so it's not going to show up very well in the blood. We're finding that only about 10% of people with mast cell activation syndrome are showing any elevation on those markers. So that makes it hard. Mm-hmm. And the other piece of this is the small sample of what can actually be tested. Well, we just talked about, we've got over 1,000 different mediators. We're only able to test for maybe less than 50. If a full panel was run, maybe 100. But most of these can be tested in research laboratories, which people don't have access to. Even, physicians don't have access to. So that's one of the challenges there. And one of the other, the third criteria is there has to be a positive response, an improvement with an antihistamine or a mast cell mediator medication, a mast cell stabilizing medication. So these are things like Benadryl, Allegra, Claritin, Pepcid. There are also medications like Ketotifen, hydroxyzine, Montelukast or Singulair is the brand name people may be aware of, Xolair, Gleefax. So there are these different tiers of mast cell mediators. And the challenge there is that other than cromolyn sodium, and Ketotifen, which is compounded in the United States, all of these other medications, as they're formulated, have mast cell triggers in the inactive ingredients. So that's so confusing because you might have somebody to take Allegra and maybe they would have gotten an improvement in symptoms, except some of the dyes triggered some mast cell activation. So now you can't even tell. This is just under debate, and it's going to take a lot of time to work through. And I can tell you the debate's really hot around it. I personally don't diagnose. That's not part of what I do. But I'm working with people who they've tried all kinds of things. They're seeing specialists. Nobody can make sense of their case. They've got symptoms in 2 or more systems. Okay, what's triggering that? Let's look at these root causes. But if you've got inflammation in the body, you've got mast cell involvement. And that's just my own philosophy there.
In our world, when we talk about, because I do a lot of GI work. So there's always underlying premise where, there's the gut dermatological gut skin presentation, and we'll see people with eczema. And of course they say, okay, get rid of the glutens and the grains, and they go through that. Or there's an autoimmune presentation, and again, you'll use an AIP protocol. But in listening to you speak, there now has to be another cog in the thought process to say, okay, maybe we should, look at this from a mast cell perspective, because we surely can't go wrong on creating, a mast cell nutritional protocol per se. And maybe it's not so much a grain thing. It could be this inflammation that's mast cell. Now, again, there are certain foods we'll get into that are high in histamine that can also create the problem, correct? So, when we change our nutritional profile for a lot of our patients, they always come in, there's nothing left to eat, and they get so just dejected. I got to eat. There's no food here. And it's really, there is a lot of food. So for us, we look at, nutrition as, as medicine, right? So, if we can talk a little bit about how nutrition plays a role in this presentation of this mast cell, which, like you said, it can be anything, because what you explained before, they come in with the breathing problems, the brain fog, the gut issues, the heart issues. And I know typically in conventional medicine, it's just like, okay, well, here's the script for that. And that's okay. They're doing their job, but no one's looking at the whole picture. I love that quiz that you have on your website. I think that's fantastic. So if we can jump into what your thoughts are, like, how do we, reframe and change our patient's mind? Like, here are the foods that you now need to eat. We're going to use this as a protocol, and we now need to eat this way.
Yeah, we could do a whole hour just on that.
Sure.
So I work with people through a systematic process. And part of that is looking at, well, where are they right now? What's their bandwidth? And how sensitive are they? And how much GI involvement and GI issues do they have? And is there autoimmunity? So there's these different pieces around then what I might recommend. The first absolutely is reducing sugar for sure, any of those packaged foods, any of the processed foods, things with preservatives, dyes, just the general cleanup. Most people who come in and work with me have already done that. Most people come in and work with me have already gone gluten and dairy free. Those are just major triggers to mast cells. I'm not anti-gluten or anti-dairy at all, but the gluten and dairy we get in this country is not clean, and it has, even the organic wheat has, I don't remember the percentage, but it's, I mean, multiple percentages of gluten above what you get in Europe. It's incredible how much additional gluten has been built into, or hybridized into the gluten that we have in this country. I have people who can eat wheat in Europe, but they can't eat it in the United States. So that the initial cleanup, just those big hitters there. Then the next layer is usually testing histamine. And like I said, not everybody with mast cell issues has histamine intolerance, but about 90% of the people I tend to work with do. So they usually will do a trial of about 6 weeks of low histamine. Then if we get some kind of improvement, they'll continue. If they don't get any improvement, then I'll have them basically challenge it with some higher histamine foods and see if they get a flare. So we're trialing that and seeing. If somebody has autoimmunity or cardiovascular issues or really severe mast cell issues, then reducing those lectins can be very helpful. And lectins are in most grains, things like wheat, corn, quinoa has lectins, things like buckwheat have lectins. So there's still a lot of things without lectins, but those are big ones. Brown rice has more than white rice. They're going to be in all those nightshades, tomatoes, eggplants, peppers. Lectins are in pretty much what you think of as what they call the New World vegetables, what was in North America. And these are also going to be things like sunflower seeds, pumpkin seeds, all the squashes, winter and summer squashes. So they usually do a trial of that, reducing those. And there's a receptor on the outside of mast cells that actually register lectins. So if that receptor is super sensitive, and it's the same receptor that registers bacteria, viruses, and molds, it's called the toll-like receptor. So people have Lyme, they have mold toxicity, then going low lectin can sometimes help people. Another trigger food category can be oxalates. And oxalates are these microscopic structures in a lot of plants. Spinach is super high, sweet potatoes extremely high, beets extremely high, Swiss chard. So I have a lot of people who came in and they got really sick on green smoothies, and they were trying so hard to be healthy, and they were doing these green smoothies and doing lots of spinach. And spinach is also high in histamine. Not everybody has an oxalate issue, but if they do, that often will show up as interstitial cystitis with urinary burning. It can show up with fibromyalgia, pain in the muscles, joint pain. Kidney stones is rare with oxalates, but kidney stones can be a presentation. So they may have to do that. That is hard to do. And I just want to tell people, don't go low oxalate on your own, please, because if you go cold turkey and oxalates, you can trigger a kidney stone. That's dangerous. You have to have a plan for really gradually reducing it. So that's not one to venture into by yourself. Then salicylates can be a trigger for some people. I see that a lot with mold toxicity. And salicylates are going to be high in most colorful fruits and vegetables. Obviously, we don't want to cut all of those out. Unless you absolutely have to, because there is really feels like nothing left to eat, and it's hard. We want to keep as much variety as possible. And I made the mistake that I've seen a lot of people make when I was trying to figure all these things out and I didn't know what was going on. I kept noticing I'd feel worse after certain foods, so I'd just take that food out until I got down to literally 10 foods, if you didn't count salt and some herbs. And I was my sickest when I got down that low. It made me ill to be that low variety. I didn't have the nutrition that I needed to for my mast cells to run, for the rest of my body to run, my detox to run. So I just want to encourage people not to do that. Always think about, if you're going to play with this, replace, don't just keep reducing. And usually, just if people just look at cleaning up their foods, get out the wheat, the sugar, the dairy, see how that does. Maybe try getting out corn because it's very similar to wheat structurally. Give a trial of histamines, and if there's a reason for it, maybe a trial for lectins. That's usually plenty of experimentation on their own. But you've got to swap. So if you're doing spinach and you're gonna go low histamine, replace it with arugula. If you're doing pineapple and that's high histamine and strawberries, replace it with apples, replace it with blueberries. Make sure you're doing these nutrient replacements so that you don't get into that trouble I see so many people get into.
And you said you like to have that protocol at least for 6 weeks, correct?
Usually about 6 weeks is a good amount of time to see and just lower that histamine bucket.
You know how there are food services where you can get, if you're following keto, if you're following vegetarian or vegan, and now paleo and primal and all that. Have you seen or worked with any food services where it's around like low histamine, low oxalate, anything like that to make it easy? Because the big question that we get is, I can't prep the food. I don't have the time. I'm running for soccer. How do you deal with that?
I haven't seen it yet, but we need to start it.
Okay, I'll be right back. Let me tell my wife, get working on that.
We need to get that going because it's true. It takes a lot of work. What I have seen work for people is to find someone who does offer that kind of service locally, who specializes in food intolerances. So if they specialize in gluten, they specialize in gluten-free, they specialize in paleo and things like that. And they really understand, like if they cook for people with celiac, they're going to understand the food sensitivities. And I've even done this for myself because as this practice grew, I ran out of time to be able to cook. So I found someone locally here who I just gave her my foods lists and I gave her recipes off of my website and said, can you make these things for me? And she brings it frozen. So it's so wonderful. It's just all frozen, but it really healthy, clean food. I can just pull it out. I do want to make a real quick note on food lists, that most of the food lists online, 99% of them, unfortunately, have a lot of mistakes. The histamine lists, the oxalate lists, the lectin lists. The only person who's really definitive on lectins is Stephen Gundry, and even the salicylate lists. And even places where you would think that those lists should be correct, they're not. So there's a Swiss list called SIGHI, SIGHI. That's very good. What's on the Healing Histamine website is very good. Yasmina Kellenson was somebody that I knew and followed for a long time, and she did good research. Janice Joneja is a great authority in histamine intolerance. Her lists are correct. And then we have lists on all these things on our site, and we have 3 people go through. So I start it, somebody reviews it, checks it, second person fact checks it against the research, and then I do the final review. That's how hard it is to get these right. So I just want to caution people, don't just grab whatever you find on Healthline or WebMD or random blogs. They've got big mistakes in them, and it's confusing.
Right. I mean, I can, as a practitioner, I use your site. So I use your site. I do get the SIGHI list. And you got some like just fantastic recipes on your site as well. And that gives the patient some hope, right? Because they feel like I can't eat this and this and this and this, and they feel like they can't interact with the rest of the family. Right. And I push them to the side, like, they're different. They can't have X, So I think that you really just the website's great and the recipes are really fantastic.
Thank you. I'm a bit of a foodie, and when I couldn't go to medical school, I entertained being a restaurant reviewer for a while until I realized that the restaurant food was making me sick too. But you're right. And it's something we underestimate is how important psychologically, socially, emotionally food is, and having something to eat. And I can tell you, when I was the most depressed and started losing hope was when I got down to those 10 foods. And I still can't eat zucchini. I just can't take it because that was one of the few safe foods I had was zucchini and yellow squash. And after you have so much chicken and yellow squash that's just steamed with nothing on it, it's, why eat?
Right. It's like,
And I love gourmet food. And so we're always trying to put out new recipes.
when we talk about the presentation, you brought up, the squash and stuff like that, and we're in the fall season here right now. And there's a lot of great squash that are out there. When you talk about mast cell, do you notice a prevalence more so on one coast versus the other coast? I mean, East Coast gets beat up bad from a vitamin D perspective for sure. But do you notice a difference? Is it like affecting one coast more than another, one country more than another? Is it more female than male?
That's a great question. So I can tell you where our concentrations are of clients. They are most of the Midwest and Mideast, all along the East Coast, the whole Gulf Coast, and the whole West Coast. Where we don't get a lot of people is the desert regions, Arizona, Utah, New Mexico. And I can tell you why. Those areas are dry,
Yeah.
and they don't have issues with mold. And mold has become, so I know you've been in practice for a good while.
30 years.
So I've been in practice for over 10 years. But when I talk to my colleagues like you who've been in practice for decades, what we're noticing is that and even from when I started, about 12 years ago, cases are more complex, they're more severe, and it's increasing exponentially. And so what used to work, even when I started 10 years ago, it used to work to fix somebody's gut, fix their hormones, boom, they're done. Okay, that wasn't bad. It doesn't work now. And a big part of, at least in my population, a big part of this is that the mold has become epidemic for various reasons. And that's what I notice is the areas that have more mold. Lots of people in the UK where it's so humid and muggy. People in Northern Europe, we've got concentrations there. We don't take international clients anymore, but we have an international community and following. And we get a lot of people there. We actually have a lot of people in India, very humid in India. So that's what I see is I see this correlation with these humid areas that are hit by hurricanes, areas that have issues with flooding, and these major climate changes going on.
You talk about mold, you talked about Lyme. But the testing for, mold and Lyme, some people, some of the docs really question it, right? So I know, they run the typical Lyme panel and then they say, well, everything's normal, therefore you don't have Lyme. When I speak to most docs, they're not, really thinking about testing for mold. So do you look at, are there specific tests that you look at for mold and Lyme that you prefer and you have more preference to one versus another?
Yeah. So, well, what I can tell you, I'm a specialist and an expert in mold, and I do a lot of work in mold. I am not an expert in Lyme, so just put that out there. I know enough to know when to get somebody on the team, and that's its own specialty. You spend your whole lifetime just getting to know that. But I can tell you that the Lyme testing, and your audience probably knows this very well, is notoriously challenging because these bacteria can go in these various forms, like cyst forms and spirochete forms. They hide behind biofilm, can't pick it up in the blood. There are a couple labs that are more reliable. IGeneX is the leader here right now, and their immunoblot testing for Lyme, their fish testing and immunoblot for Bartonella, and their fish testing for Babesia. That's what's been most highly respected. And I mentor closely under Dr. Neil Nathan, who does know a lot about Lyme, and that's what he always tells me to use. The mold toxicity, so mold, the two best tests are RealTime and Great Plains for mold right now. Those are the two most reliable. And if people can only get one, RealTime is the one to get. And then Great Plains tests for a few other things, and they're more sensitive for a couple of the mold toxins. So if people have a budget for it, I want to see them both side by side. Those are urine tests. And those are accurate. What's tricky about them, though, is mold toxins are fat soluble, so they're stored in the tissues and they're not easily circulating in the bloodstream. So it helps if people can do some sweating beforehand, or they can do some manual lymphatic drainage. There's those kinds of videos on YouTube on how to do that on yourself. If you can do some exercise or sauna, if they tolerate it, these kinds of things helps show some of those toxins in the urine. Some people who can tolerate it use some glutathione beforehand. And then what we have to know is that most of people who are really chronically ill are poor detoxifiers, and they can't excrete toxins very well because of something called cell danger response, which is a protective mechanism in our bodies. When we have these toxin loads or pathogen loads, it's stopping us from excreting these toxins, so they're not circulating into the brain and the other tissues. That means we're going to see very small levels for most people with chronic illness on these mycotoxin panels. And a lot of times they're told, oh, that's not really an issue. And I've had people come in, or it shows below the cutoff of what the lab is saying is an issue. But if somebody's chronically ill, you have to take that seriously, because you should have zeros on these tests. There were studies that showed that they looked at people with mold toxicity and a control group without. And they were looking, well, does everybody have mold toxins in the urine? And the study concluded, no, we should not be seeing these show up on these tests, even in what looks like a small level. And if people go through the mold detox, work through that, they'll see those levels start to come up over time as they get stronger and they can excrete. And then it finally, you can see more of what's in the body. But too many people are being told it's not an issue because it looks low on that initial test.
Interesting. Okay, so hygienics for the Lyme, which I've dealt with before, and I deal with Great Plains. And the other one you talked about was RealTime.
RealTime is more sensitive for gliotoxin, trichothecenes, zearalenone, and aflatoxin.
Gotcha.
Great Plains is more sensitive. Their mycotoxin test more sensitive for ochratoxin. And then they also have some other things like eniatin B. They have mycophenolics, citrinin. So you can see where that helps to put them side by side. Yeah. Sometimes Great Plains will pick up the ochratoxin when RealTime won't. And then sometimes Great Plains will show some of these other ones that RealTime doesn't test for. They have different testing methods.
Gotcha. But either if they show up on either side, we have to get those toxins out.
We want to get those out. This is just, like I said, the number one root trigger. This is what turned my health around. This is what I've worked with over 600 people. And I mean, I've had these huge turnarounds. People with Parkinson's, getting that Parkinson's turned around. I had a young woman who was having 20 seizures a day. She was in a wheelchair. She was 19. She couldn't make full sentences. She wanted to go back to college, and she could talk at about a 6-year-old level. She was just so affected. And with doing that mold detox, she was out of that wheelchair. The seizures had stopped. They had to clean up mold in the environment. She was about 6 months later writing full sentences and talking like a normal 19-year-old and applying to go back to school. So this is a kind of turnaround, and not everybody's that severe. Right. But if those mold toxins are in there, they are some of the most toxic. I mean, these mold toxins are being used in bioweapons. Most people don't realize that. And they are ochratoxin, aflatoxin are highly carcinogenic. They're behind a majority of the cancers that people are experiencing, and this is not being discussed enough.
All right. And when you say, toxin and detox, I just want to make sure that everybody listening understands, like, we're not talking about like going through one of those detox protocols, where, we're detoxing, we're having a juice detox, right? We're not talking about, we're talking about a true detoxification.
Really targeted. Yeah. And we have I was on a research team. I was really fortunate to be on a research team with Neil Nathan, Dr. Joe Mather, Emily Givler, and Matthew Miller was involved in this. And we combed through every piece of research data we could get our hands on and how these mold toxins are metabolized. And it took us over 6 months. There were just hundreds and hundreds of studies. But we mapped out, this is so exciting, we mapped out, Joe Mather did a lot of research and Neil Nathan on the binders and mapped out which binders, and we're continuing to work on this, are best targeting which mold toxins. So this is why you want to know which ones you have so that you can target it, because a lot of people are just taking a blanket binder or combo binder, and then they're only getting maybe 20% of what's happening in their body. Then we mapped out the phase 2 detox pathways for each of these mold toxins and which need to be supported. And what was so interesting is glutathione is barely used by our bodies to get rid of mold toxins. It's a pathway nobody talks about called glucuronidation. And that's the pathway that we need to support the most with when people have mold toxins.
Yeah, I'm a fan of glutathione. So we use that. It's great. All right. So I have some other questions to ask. One is the connection between mast cell, histamine, MTHFR, and do you treat the mast cell? Do you treat MTHFR? Like, what is the thought process behind that?
Yeah, that's a really good question. So one of my other loves is genetic analysis. And I'm certified by Dr. Bob Miller, and he's one of the leaders in functional genetic analysis. And I'm on his research advisory board. And we have, one of the really fascinating things about what he's done is he's collected a database of 40,000 people with chronic illness and how common these different variants show up in this chronic illness population and how significant they are. What's so fascinating, and this is going to shock some people, but what's so fascinating is that we have found that MTHFR is not even in our top 20 list of most significant genetic variants. But it was the first gene that really got attention and research in these kind of functional areas. And then people built their empires on it, right? So that's where it just became so popular. But MTHFR, for people that aren't familiar with it, is what it's doing is taking folate in our body and adding a methyl group. So it's methylating the folate and then allowing that to support this methylation cycle. This methylation cycle actually has over 20 enzymes involved above MTHFR. So that's one problem, is that MTHFR became huge and it's not even the most important gene in the methylation cycle. But it is a gene that's important. This methylation cycle is used in detoxification, DNA repair. It makes glutathione, all kinds of roles and responsibilities. It helps with activating our melatonin, breaking down certain neurotransmitters. It's necessary to help break down histamine. So that's the connection. And the tricky thing, though, is that when people have chronic toxins, chronic pathogens, this cell danger response I touched on, this cell danger response is like a lockdown process to protect us. One of the things it does is start to change our methylation cycle intentionally to protect us. A lot of times people are barreling in with high dose methylfolate and B12 to push that methylation cycle. Works great for some people. We have to be careful because really high dose methyl B12 and methylfolate also will drive another metabolic process called mTOR, which cancerous tumors hijack to replicate. So that's one thing I would caution people, these super high doses. A lot of people don't tolerate methyl B12 and methylfolate and when they're sick. And it's because of this. You're working against what the body is trying to do to protect you. So methylation is something that we deal with. It's way down the track, doing a detox program and turning these mast cells around if somebody's not tolerating it. So there's a timing to all of this that we have to start bringing in with this kind of order of operations. So a lot of times, all of that to say, a lot of times you can't fix methylation early in, and it's not the top priority. So, and I've also had people with MTHFR variants who didn't have methylation issues, which tells you something. Mm-hmm. And then you can have functional issues. So people with no variants and they had methylation issues. But it's not my top priority when people come in. My top priority is to actually calm their nervous system, work on their nervous system signaling, calm their mast cells, clean up their diet if they need to, and then check them for toxins and see what's going on, and start a very slow, gentle detox process.
Gotcha. And do you believe there's a role in MCAS with fibromyalgia?
Yes, yes. It's been linked in the research, fibromyalgia. So a lot of what my thinking is always, well, why? And I think that's what really got me through, was I was always asking, okay, but why? I was told that I had rheumatoid arthritis. And a rheumatologist told me at the time that I was misdiagnosed, that I'd be in a wheelchair within about 2 or 3 years. And I just said, well, but why? Why is this happening? If we know why it's happening, we can turn it around. And with the fibromyalgia, again, we go, well, why are the joints, or why are the muscles so painful? And I had severe fibromyalgia. A lot of times there's inflammation in the muscles. There can be oxalates involved, mold toxins, and sitting in the muscles are painful. Then we get that stuff out. Those mast cells, if you get out what is just this constant onslaught, the mast cells a lot of times over time will re-regulate. And that's the really exciting thing.
And you talked about cell danger response. You talked about cytokine, and everybody is an armchair immunologist right now, and everybody knows they're looking at cytokine. But in reality, with COVID, we are seeing, especially with long COVID, almost like that MCAS presentation.
Yeah, it is MCAS.
Okay, so I want to know if you can touch base on that, because it's very prevalent now.
Yeah, it was really suspected even early last year that this was likely a mast cell involvement with these cytokine storms. And then the studies have come out since then, really demonstrating that that's what's going on. So what's behind these cytokine storms is one of the mast cell mediators called IL-6, interleukin 6. It's an inflammatory one. And I've had a lot of long haulers who came in who didn't have these mast cell presentations before then. But then after, post-infection, they had all of these mast cell type symptoms. And what's been very interesting, and, everything's experimental, and I don't treat. So again, I chose not to become a licensed medical provider because of the consulting I wanted to do. But I'll recommend ways to help support people's natural processes. So when I would just do what I knew to do, which was to recommend mast cell supports and things that help the mast cells, has been making a tremendous difference, making a lot of change for people.
Excellent. And another question, second to the last question, I'm gonna have another question after that, but the most lifestyle change that you would recommend somebody to have when they're dealing with mast cell? Work on sleep or work on exercise?
Oh, that's a great question. So if we're just choosing sleep and exercise, that makes it easier. It's everything that I do is individualized, and people email me. I have had lots of practitioners email me and say, what's the protocol for Mast Cell Activation Syndrome? And the best I can do is a little tongue-in-cheek, playfully say, well, do you have 6 months?
Right.
We're going to need 6 months, 40 hours a week to go through this, because it has to be per person. But between sleep and exercise, hands down sleep. A lot of times the cell danger response, again, this was groundbreaking research. It was done by Robert Navio. And I've learned a lot about it again through Neil Nathan, who does a great job of distilling it down. But one of the other protective mechanisms is to increase fatigue, so that we will rest and not waste our energy that we need for healing and protecting our bodies on going and climbing that mountain or riding that bike that extra mile. So that fatigue is protective. And I had some people also tell me, well, you just need to exercise more. And I couldn't get past 10 minutes. I'd just crash. And I kept pushing and pushing. And then that 10 minutes would get shorter and shorter, I could tolerate, until I understood what I was doing to my body. Sleep, much bigger. That's going to really help the cycle. And we've got to get this cell danger response rebooted to get back to what people are told is your normal healthy lifestyle, exercise, and the things that we know we should be doing. Doesn't always work when we're in these lockdown areas with chronic illness.
Gotcha. Fantastic. So, you got that great quiz on your website. You got those incredible recipes on the website. How can somebody work with you? What would be their next step? What do they need to do?
What I would really recommend is I have been developing courses to help people step themselves through these things. I'd recommend that symptom survey, first of all, to see if this might be going on. And then if so, these courses are being rolled out in the order that you would go in. So we have what I call the Mast Cell Nervous System Reboot. That's the first one. And the mast cells are at every nerve ending. And the mast cells in the nervous system communicate back and forth continually. Stress, we completely underestimate this. Stress is one of the big, big triggers, and a history of trauma. And I can tell you, every person who's ever come through my practice has had nervous system dysregulation. I have not met a single person with chronic illness without nervous system dysregulation. So this is a signaling of the nervous system, and it helps with sensitivities and so on. So there's a course on that. There's a course on the top 8 mast cell supporting supplements to get people started there. And then I just released this really in-depth course on how to do a mold detox when you have mast cell issues, when you have sensitivities, and the normal, stronger approaches aren't working. How do you do this really gently and paced? And it steps people through that, from how to test themselves, how to look at the tests, how to pick their binders, how to troubleshoot things like if they're having trouble constipation, and takes them all the way through the antifungals.
Absolutely beautiful. That's fantastic. And I'll share it with everybody when we put this back up again, because everybody will get the recording of this as well. And the last question is, what book are you reading now?
Oh, that's a great question. Well, I always have about 20 books going simultaneously.
I figured, what book you're reading now. I mean, I'm sure we all do.
And but one that I really enjoy is called Born to Run.
Oh, I just sent that to somebody. It's one of my favorite books.
Yeah, so it's such a good book about, and what I'm really reading about is a group of native people in Mexico called they call themselves the Raramuri, and their other people, outsiders usually call them the Tarahumara. And I'm really fascinated by how they live and their lifestyle and how healthy they are. And they do these epic runs for 2 days. They might do 90 kilometers, and they do it barefoot, or they do it in these little sandals they make with rubber. Yeah, with the tire treads. I'm just really looking at how they're so connected to the earth.
Yep. It's a great. I am not a runner. And
I'm not either.
It was a fantastic book, and somebody gave it to me and said, "You got to read this book." And I just gave it to a patient as well. I think it is such a wonderful, wonderful book. And you don't have to be a runner to really enjoy the essence of that book. Definitely top of my list. So very cool you're reading that. Beth, thank you very, very much. This was great. There's a ton of questions that have run through my head. There might be round 2. Who knows? Thank you very much. Appreciate that. Everybody will send out a copy as well.
I love it. Thank you.